post-operative period. I have the honor to introduce my dear professors, Professor Samir Naim Assaad. He's one of the eminent speaker. He was the head of the Department of the Internal Medicine and the head of our endocrinology department. Please, Professor Samir, you can start.
Thank you very much, Professor Alia. Thank you very much for the invitation and for the kind introduction. Thank you. It's an honor to share with you and Professor Khalid Yusuf and Professor Tamer Sherbini. Thank you. Let me load my slides, please. Okay. Is it okay, Dr. Amai? Is it okay?
Yes, doctor.
Yes, Professor.
You see the second slide?
Yes, I can see it.
The second slide, okay?
Yes.
Okay. Okay, I will be talking about the problem, although it's not very common, but it's really difficult sometimes to deal with. And even for the general practitioner, he should be aware about this problem of post-thyroidectomy hypoparathyroidism, because now the thyroidectomy is done for several reasons. I'm really making this talk in the memory of two ladies, which we have seen several years ago. I will start by the first lady. She is a 55-year-old lady admitted to the ER back in 1988 with stridor. And she had thyroidectomy 5 days earlier, and urgent ENT consultation by the ER doctor ended with tracheostomy. She was seen 2 months later at our clinic in the endocrinology unit. And this is the photograph of the patient. You can see definitely the scar. This is the scar, and this is the tracheostomy with this granulation tissue, and the typical puffy face of post-operative hypothyroidism. Because she wasn't started yet on Eltroxin or Thyroxin or Ucerox, whatever. The second lady, she is a 78-year-old lady. She had near total thyroidectomy for euthyroid big nodular goiter. Pre-op lab tests were all normal. Immediate post-offer, she was given by the surgeon 6 tablets of 500 milligrams calcium carbonate and 3 tablets per day of 1-hydroxyvitamin D. 15 days later, she was admitted to the ICU with disturbed consciousness. And the blood urea at that time was quite elevated creatinine, and very high serum calcium, 16.2. And remember, the normal is in milligram is between 8.5 to 10.5 total calcium. Actually, she had hemodialysis followed by deterioration of the level of consciousness, and unfortunately, she was intubated and passed away 2 days later. Actually, when we talk about parathyroid, we have to go back to a little bit of history. The parathyroid glands were first discovered in the Indian rhinoceros by Richard Owens in the UK. And while actually in the human being, it was covered by a medical student from Sweden, Mr. Victor Sandström. And the thyroid surgery was actually founded in the late 18th century by Theodor Bierroth from Vienna, and Theodor Kocher from Switzerland. And actually they had described the precise anatomical dissection of how to do thyroidectomy and ligation of the 2 principal arteries before that. But actually we as Egyptians, we were pioneer in describing this, and the famous Edwin Smith papyrus. This papyrus was described by the ancient Egyptian and this was in 1600 years before Christ. And nowadays, the indications of thyroidectomy is mostly done for big symptomatic benign thyromegaly, or if there is concern about malignancy, or if there are hyperthyroid conditions like Graves, resistant to treatment, especially if associated with increased size. This year, 2021, actually the performance of thyroidectomy should be less practiced, because nowadays we've got very super sensitive, high resolution thyroid sonography, which will allow us to risk stratify in a better way the nodules, and to apply the modern adaptation of the Bethesda classification of the fine needle aspiration. So, but these two tools, we should not operate on every patient with thyroid nodule, whether alone or with Graves' disease. The post-surgical hypoparathyroidism, actually in different series, it differs. So the percentage differs from 1 to 7% of post-thyroidectomy hypopara. And thanks God, most of the cases, 75% is transient, while 25% is chronic or permanent. Transient is due to actually impairment of the blood supply, while the permanent one is due to necrosis or actual excision of the 4 parathyroid glands. And by temporary or transient, we usually mention 12 months. So you should wait for the patient, but after 12 months, if he is still hypocalcemic and hypopara, this means it will be permanent. All right. What are the risk factors to develop post-thyroidectomy hypoparathyroidism? Of course, if the patient has got multiple surgery, if they're doing extensive surgery with substernal goiter, surgery for Graves' disease, particularly Graves' disease and females, because usually they are being prepared by preoperative beta blocker. For strange enough, Graves' disease, females, preoperative beta blockers are considered one of the important risk factors for developing post-thyroidectomy hypoparathyroidism. The age more than 50 is another risk. And if the surgeon is trying to identify by good intention the other or the 4 glands, if he's trying to identify him, sometimes this is bad because he will interfere with the blood supply. I will mention that later, inshallah. You can decrease the risk of post-surgical hypoparathyroidism, of course, by finding an experienced surgeon, because this is it's very important. And nowadays, we are using the intraoperative PTH before sending the patient to his room. We measure the PTH intraoperative to be sure that the parathyroid glands are functioning. And to remind you that if you remove or you have ischemia of the 4 parathyroid glands, you get lack of movement of calcium from the bone, and this will lead to hypocalcemia. At the same time, in the absence of PTH, the kidney will not be able to retain the calcium. So the calcium reabsorption is impaired, while the phosphorus reabsorption is exaggerated. This will lead to hypocalcemia again and hyperphosphatemia. So hypocalcemia and hyperphosphatemia are the main golden rules for the diagnosis of post-operative hypopara. Of course, PTH is important, as you remember, for the activation of vitamin D. So if you don't have PTH, the vitamin D will not be activated in the kidneys. So there will be impairment of the calcium absorption, and this will lead to more and more hypocalcemia. Clinical manifestations, as you remember from the medical school, the typical tetany, the carpal spasm, as you see, flexion in the wrist and flexion in the metacarpophalangeal, while extension in the interphalangeal is very famous. Sometimes you do the Tvosted by tapping on the facial nerves. You will get twitches on the same side of the face, while true sure sign, if you inflate the blood pressure cuff above systolic and wait for a few minutes, you can induce the tetanic or the carpal spasm seen in the photograph. But mind you, there are other manifestations like numbness in the lips and in the tongue, muscle twitching, weakness, headache, fogging, or what we call altered sensorium, and most important, EKG changes, the form of prolonged QT interval, which is fatal. In long-standing cases, you can get increased bone density, with calcification in the lens of the eye and in the basal ganglia. As you see in this CT of one of the patient, the basal ganglia, this is calcification. This is one of the long-term complication of post-thyroidectomy hypopara, or even in the idiopathic hypopara. But mind you, we have to remember that the hypocalcemia and the hypoparathyroidism may not develop except after 1 or 2 days after surgery. So if the patient was discharged early in the hospital after 1 day, this doesn't mean that he will not develop hypoparathyroidism at home. So we as a physician and the surgeon, they have to remember that notion. Can you predict the post-thyroidectomy hypopara? Yes, more or less. If you measure the serum calcium 1 day after surgery, before discharging the patient home, before giving him any calcium, if it's less than 7.5, this means that the patient is going to have hypopara. Or if you get a decrease of serum calcium before in comparison to after by 1.1 milligram. So a decrease of calcium, if you compare it to the pre-op, more than 1.5 milligrams, this means that the patient will develop hypoparathyroidism. 1 hour post-operative measurement of PTH also is useful after surgery. If it is less than 12 picogram, this means a prediction for hypopara. Or 1 day of PTH level less than 10 milligrams. So on discharge, you have to measure PTH and calcium. If it's less than 7.5 and less than 10, you should be very cautious and even start treatment immediately. Another new technique is to measure the serum PTO in the operating room before sending the patient to the ordinary ward. And if it's less than 10, this means that there is a risk of hypopara. How can you prevent the post-thyroidectomy hypopara? Let's see the data. This is one of the notions. Now the surgeon, they like it very much. They call it the parathyroid splinting. By parathyroid splinting, they give immediately after surgery high dose of vitamin D and calcium. Even sometimes, unfortunately, without follow-up. And this can be dangerous, as it can lead to hypercalcemia, which can be fatal. Although parathyroid splinting has been recommended now by different surgical authorities, but we do recommend that actually to follow this patient very, very closely, not after a month or 2, as we usually do for outpatient patients. And also, you minimize the risk, of course, by choosing the good surgeon, as I mentioned, by choosing good surgical tools. It's not important for us, of course, physician, but for the surgeon, they know very, very well the conventional technique to be used in comparison to what we call the ultrasonic harmonic machine. And you can see that definitely by using these machines in way to cauterization, the injury to the parathyroid is much, much less. Also, if the surgeon is trying to preserve the parathyroid, you see, this would be very useful. And they have been recommended to preserve what they call the inferior thyroid vein. So if they cut the inferior thyroid vein, the rate of hypopara post-operative is quite high. So one of the recommendations for the surgeon is to preserve this vein. And nowadays, they do inject what you call indocyanine fluorescent green. And you can see that the surgeon, before sending the patient or closing the wound, is sure that this is the parathyroid is viable by indocyanine green, fluorescent green imaging. He can image, be sure that this is a parathyroid. This is after injecting substances, it is green. This means that this tissue is viable. So at the end, we have to talk shortly about how to treat. So I did talk about how to diagnose. So we've got the clinical data, the laboratory data, and what are the risk factors for developing post-operative hypoparathyroidism and how to try to prevent it. Now let's talk a little bit about the treatment, because we are much concerned as physicians about this item, because we are going to follow the patient, not the surgeon. So we need to spend some time, maybe 5 minutes, about how to treat. In short, you have to give calcium carbonate orally in a good dose, or sometimes you can use calcium citrate. I will show you the data. You should use vitamin D in the form of active vitamin D, the 125 hydroxy vitamin D in this dose. Sometimes, because calcitriol is not available in Egypt, sometimes you can use the 1 alpha hydroxy vitamin D. Also is useful. If you don't have either, you can use the ordinary natural vitamin D, but you have to give it in high dose. You see, 25,000 to 100,000 units per day. Why is that? Because remember that vitamin D needs to be activated in the kidney under the effect of the parathyroid. If you don't have parathyroid, the vitamin D won't be activated. So you have to overcome this step by giving higher doses of oral vitamin D. Small dose azides have been used since I was a fellow, maybe in USA, almost now 40 years ago, but still nowadays we are still using it to prevent, I will show you data, to prevent what we call increased calcium in the urine. Because in this patient, you can get, after surgery, after treatment, increased calcium in the urine, and this will provoke calcium stones. And this is sometimes very bad for the patient. Lastly, but not least, there is room now for the recombinant PTH, if it is available. Now that we've got the 134 available in Egypt, used to treat osteoporosis, and we are using it off-label, but abroad they are using the 184 PTH, and they've got problems with that, and they are seeking for new formulations, and I will show you some data. In emergencies, when you see the patient, you have been called by one of your patient or patient of other doctors that after surgery he is developing tetany, and he is developing even vocal cord contraction due to hypocalcemia, and sometimes fits, GI fits. You have to start immediately IV calcium gluconate in infusion. And if it is persistent, you can use 10 ampoules of intravenous calcium gluconate, and please put it in D5, not in saline, because if you put it in saline or saline will increase the calcium excretion in the urine. So you need to preserve the calcium. So it's better to put it or to dilute it in D5, dextrose 5%, and give it every 8 or every 12 hours. Of course, you have start also at the same time oral vitamin D or injectable vitamin D if the patient cannot swallow. And sometimes the use of magnesium sulfate is useful, because this will increase the sensitivity of the cells to the PTH. What about calcium? As I mentioned, calcium carbonate has been used, but it should be given with meals. Please prevent it. Remember that. If you want to use calcium citrate, because it can be given without any meals, it's another advantage. And the dose is variable between 1 gram to 9 grams. You can use up to 9 grams per day, but it's better, and I repeat it, it's better to split the dose to maximize absorption. But I want to mention something here, because we have heard from Professor Alian, Professor Tamer, and other colleagues that calcium intake at the same time of the thyroxine pills will impair the absorption. So you have to be aware about that and keep a distance if you are going to use multiple doses of oral calcium. Vitamin D is important because it will enhance calcium absorption and stimulates the bone remodeling, and it will stimulate the activation of the PTH activation needs to be stimulated by the PTH. As I mentioned, that if the PTH is absent, if you use vitamin D, the ordinary one, you have to use high doses of vitamin D. But you can use the active vitamin D, the 125 dihydroxyvitamin D, or the 1-alpha hydroxyvitamin. You can use it in a dose here. They can use it up to 2 grams totally of calcitriol, and even for the 1-alpha, you can use up to 4 micrograms per day. And if the dose is more than 1 microgram, it's better to divide it. Please remember that. And you have to follow up calcium very closely every 3 to 4 days after initiating that. And recent advice by experts that sometimes you can combine the 1-alpha hydroxyvitamin D with either the ordinary vitamin D. So we are doing now to give injection of vitamin D, say the 200,000 unit vial, the famous vial, which is very cheap, every week in high dose, every week or every 5 days intramuscular, in addition to the available 1-alpha hydroxyvitamin D. But you have to follow the patient very, very closely. Now, another important notion, this was given when we attended the talk of Dr. Lars Lenmark from Denmark. This was 2 weeks ago in the Endocrine Society meeting. Of course, it was over the web. And actually, he mentioned 2 different approaches. Should we give high dose of calcium to correct the post-operative hypopara with a relatively low dose of active vitamin D, or low dose of calcium with a relatively high dose vitamin D? And actually, this was rather new for us, because actually he has chosen to use low dose of calcium with a high dose of vitamin D. Because in most of our prescription, we used to try to give 6 or 8 tablets of calcium and moderate dose of vitamin D. But he usually is recommending to actually to decrease the dose of calcium and to put more weight on the vitamin D. And the rationale, his rationale, that PTH is not the only hormone missing after surgery. No, another hormone, which is the active vitamin D. So in hypopara, he mentioned that, this is his own words, is a 2-hormone deficiency disease. So we have to compensate by giving vitamin D in addition to calcium. Good dose of vitamin D. Because he did mention that high doses of calcium can lead to more burden of pills. As I mentioned, you can give, sometimes people can take 12 tablets of calcium, and it will interfere, of course, with the absorption of thyroxine. There is GI discomfort with the calcium. You cannot imagine patients say, oh, the calcium pill is quite big, unless you use chewable one. The hypercalciuria is very important, because hypercalciuria is a risk factor for renal calcification and renal stones after surgery. So you say, hypopara, Dr. Assaad, leading to stones. We have heard in the medical schools that hypoparathyroidism is the one leading to stones. But yes, hypopara, if you try to correct it, I will show you now the slide. If you try to collect it by raising the calcium, you will end by high flow of calcium in the urine. And this is a cartoon I have made myself. This is a normal person, and this is the barrier of the kidney, what we call the renal threshold for calcium. And this is the normal serum calcium. Say it is 9 milligrams average. So 9 milligrams, it will not overflow to the urine. This is the urine side of the kidney, and this is the plasma side of the kidney. But if you get hypopara, say after surgery, the serum calcium will be low. Are you going to get hypercalciuria? Of course not, because there is no overflow to the kidney. But what about if you start treating this patient by giving calcium and vitamin D? By giving calcium and vitamin D, you will raise the calcium. It will be normal, but it will be overflow because the renal threshold is not raised by vitamin D and calcium. So this is an important notion to remember, because usually clinical practice, we forget to follow this patient by measuring the urine calcium during treatment. So we have to concentrate on that. One cheap drug, although sometimes it's available now in Egypt, the pure hydrochlorothiazide pill. The hydrochlorothiazide is actually increasing the threshold. It will diminish the calcium excretion in the urine. So it can be used in small doses. You can start by 12.5 if you are afraid of dehydration. Sometimes you can go up to 25 milligram tablet per day, and it will enhance the distal renal tubular absorption, and it will lead to reduction of the urine calcium less than 300 milligram 25. Please remember this figure. Please keep the urine calcium in your patient followed after surgery with hypopara in whom you are giving calcium vitamin D. Please keep the urine calcium less than 300. And you have to monitor, of course, the potassium because of the drop in the potassium with the cyanide. So let's compare vitamin D and PTH now. Vitamin D, of course, you will raise the serum calcium, so it's good for your patient, but it will raise the serum phosphate as well. And remember, in post-operative hypopara, the serum calcium is low, the PTH is low, but the phosphorus is high because there is lack of excretion of phosphorus. So what you need to correct the hypercalciuria by giving the PTH, and this was a new notion of using the parathyroid replacement therapy, because this was the only hormone up till now not replaced. We used to replace thyroxine, replace cortisol, aldosterone, and so on, but PTH replacement was not available up to recent, and now with the Recombinant 184, what we call the NAT-para, which was introduced in Germany too. But now there was a recent report that have got a technical problem with cartilage. If you pierce the cartilage several times, you get impurities. So now they have problems with this in the USA. Of course, we don't have that in Egypt, so we don't have this problem. But now they are formulating new agents, I will say. So this is the intact parathormone, and this is the Paratide 134. This is available in Egypt for treatment of osteoporosis, but sometimes off-label. Sometimes we use it in resistant cases of post-operative hypopara, sometimes. And it's very effective, the Recombinant 184 full length. It decreases the need to give the calcium. It increases the need of or the dose of vitamin D by 50%. So it's very useful drug as well. And there are few emerging therapy. Now we are talking about long-acting PTH analogs. We are talking about the PTH receptor agonist oral one. They are talking about the calcilytic drugs, the antagonist to calcium sensing receptor. And they are talking now in the last endo meeting, was a few months ago, a few weeks ago, about a new preparation they called Transcon PTH, which is available in phase 3 and not, of course, available in Egypt. Before I leave you, I'll give you a clinical tip. Clinical tip that sometimes if you are maintaining your patient with good dose of calcium and vitamin D, and sometimes he comes to you even with statin. Of course, the most common cause is the patient not remembering or to get the vitamin D and the calcium. But sometimes if he gets diarrhea, gastrointestinal disease, hypomagnesemia due to intake of any other drugs, or the intake of glucocorticoids, this will lead to lowering of hypocalcemia, and most importantly, anti-resorptive medication. And this medication I use for treatment of osteoporosis. And I remember a patient taking denosumab the famous injection subcutaneously every 6 months for the treatment of osteoporosis. And the first time she got this injection, she was in the ICU because of hypocalcemia, because she was operated, as I mentioned, thyroidectomy, post-thyroidectomy hypopara. Of course, you have to remember that to avoid hypercalcemia, you have to avoid overdose. You have to avoid the decreased daily fluid intake, because these are the main causes of hypocalcemia: high dose of vitamin D, calcium, decrease in the fluid intake, decrease in renal function, intensive sun exposure, and if you use calcium-containing phosphate binders, because sometimes you treat the hypophosphatemia by using calcium phosphate binders. And of course, immobilization. You have to avoid this if you want to avoid hypercalcemia. Madam Chairman, ladies and gentlemen, I'll go back to the few cases I presented early. And I have to remind you, the first lady, these are true ladies, these are actually, this is actual photographs. This was in 1988, when we didn't have digital camera. We used to use the ordering slides. And she had, as I mentioned, thyroidectomy. After thyroidectomy, she was admitted to the ER with stridor. Now, prepare your polling system. Dr. May, please. This is the first question.
Yes. Okay. Let's start.
The first question: if you were at the ER in the place of the other doctor, what would you have done differently before consulting the ENT? So, if you are the place of the ER doctor, 1988, what would you have done before consulting the ENT? Option A, measure calcium. B, perform a quick chvostic test for your patient. C, A and B, or D, oxygen administration. Please start vote. Please kindly vote. So give them, Dr. May, please, 30 seconds.
Sure, doctor.
Okay. Can you get the results, Dr. May?
Share result.
Okay, thank you very much. Okay, great. Now everybody is happy that you got the knowledge. Of course, this patient, as you see, this was not a case of stridor due to bilateral recurrent nerve injury, because the ER at that time doctor thought that this is a post-operative bilateral recurrent nerve leading to stridor. That's why he called the ENT. But you have to remember that we have to perform a quick chvostic and measure serum calcium. In 1988, measuring serum calcium in our hospital was a miracle. It was very difficult. Nowadays, you can do it in a few minutes. So the best option actually to perform the chvostic sign and measure serum calcium. So I agree with the majority of you. Thank you very much for your. Okay, let's go to the following slide. Okay, so the option is A and B. Let's go to case 2. Remember the 78-year lady who had the thyroidectomy for a big euthyroid goiter, not for Graves. And she was given by the surgeon 6 tablets of 500 milligram calcium carbonate. This means it's 3 grams per day, although it's not a big dose, but yet it's 6 tablets per day. And 3 tablets of 1 microgram, 1 alpha hydroxy vitamin D, because it's available in Egypt. And 50 days later, she was admitted to the ICU with a sensorium. I remember her very, very well. And the blood urea was shooting when she was admitted to ICU. It was normal before surgery. Creatinine, she developed achy eye, due to marked hypercalcemia. And hypercalcemia was induced by giving the vitamin D and the calcium in this dose. Now let's go to the question about this lady. What you have done differently. So if you're the place of the surgeon or if you had option to see this patient immediately after surgery as a physician, would you have done differently? So please answer. Would you have done differently? A, do not give calcium or vitamin D post-op, never. Or give a smaller dose of calcium and vitamin D. Or give calcium and vitamin D as a surgeon did, and as most of the surgeons in Alexandria are saying in Cairo, they're doing the same, and giving a good dose of calcium and vitamin D with close calcium monitoring. Please vote. It's very kind of you to vote. Thank you very much. I'll give you 15 seconds more. Okay, Dr. Amay, let's go.
Yes.
Of course, you agree 100% with what I have written. In this case, it's not change. In this case, best option. Okay, go with the surgeon, but measure measure calcium every 2 or 3 days. Please do that in order to avoid what happened to this lady. So, in this committee, this is the data, and this committee routine prescription of calcium vitamin supplementation to patient with post-thyroidectomy biochemical hypocalcemia, as recommended by several surgeons, can lead to unnecessary treatment in most patients. The last case I'm going to discuss, this is a 40-year-old lady, total thyroidectomy with lymph node dissection, not for Graves, but this was for papillary thyroid CA, and post-operative she developed muscle cramps, spasm, and tingling. Serum calcium was low in the range of 7.2 to 8.2. Phosphorus to the high side, normal is up to 4.5, and the urine calcium was tendency to, this is after giving her this is with treatment. And although the physician was not able to control the calcium because the patient was having episodes of hypocalcemia, so he had difficulty with that. So the patient post-operative, and this is the data post-operative, and actually 5 years later in this lady who had been used vitamin D and calcium to correct her hypocalcemia, she developed bilateral cataracts and nephrocalcinosis, which is sometimes leading to chronic kidney injury. So please, my question is, please go to the question. Hypocalcemia in this patient can be reduced by one of these options. Please start voting. Okay, Dr. Amay? Adjusting the dose of calcium and vitamin D to keep the serum calcium in the high normal range, or give furosemide as diuretic, or give high sodium diet, or give PTH replacement therapy if it is available. So you've got 4 choices to avoid hypercalciuria and nephrocalcinosis and renal failure in this patient, given calcium and vitamin D for post-operative hypopara. Please vote. I'll give you 30 seconds. Okay. Can we get the results, please? All right. So here we got a diversion. Although the majority, 43%, they voted with PTH, which actually is a correct answer. Of course, you have to avoid the 3. So definitely, you have to avoid keeping the calcium in the high normal range, because I did show you the slide with a cartoon about the renal threshold. So if you raise calcium above 8.5 to 9, you will get hypercalciuria. So in this patient, you have to keep the vitamin D and calcium dose to keep calcium in the low range. You have to give thiazide, not furosemide, because furosemide will increase the calcium loss in the urine. Okay, but give thiazide. Thiazide will decrease the calcium loss in the urine. And of course, avoid high sodium diet. If you are going to tell the patient to use a low sodium diet, they be protected against hypercalcemia. So remember 3 things: avoid high sodium diet, give thiazides, and keep the calcium and vitamin D dose to keep the serum calcium in the low dose. If you got the facility to get the patient PTH, will be okay. So actually the correct answer is PTH replacement, not definitely the other 3. So at the end, let me remind you that the goals of treatment in post-operative hypopara is to ameliorate the symptoms of hypopara, particularly the numbness, the brain fogging, and the tetany. You have to maintain calcium in the low normal range, maintain phosphorus in the high normal range, avoid hypercalcemia, and avoid elevated calcium phosphorus product. It should be less than 55. If you multiply calcium by phosphorus, it should be less than. These are the recommendations. So at the end, my closing comments and the take-home message is: managing patient with post-operative hypopara is challenging. Low post-operative calcium, 1 hour to 24 hours calcium and PTH predicts hypopara, as I mentioned. Caution about routine use of calcium vitamin D post-operative. You have to follow the patient closely. Remember the second case who developed renal failure. Please remember her. Permanent hypopara can be 6 to 12 months. So if the patient is, you see the patient 2 years or 3 years after surgery with the same problem, this means it will be permanent. Measure of urine calcium, usually forget to do that, but please do it. Keep it less than 300 milligrams. And if you got the facility to use a PTH formulation, whether the old one, which now the net para, and I mentioned to use it only once, the cartridge, and throw it away. Is very expensive. We don't have it anyway in Egypt. And you can use it in order to achieve control in spite using high dose of calcium and vitamin D. And the goal of hypopara, remember, keep the serum calcium between 8 and 8.5, keep urine calcium less than 300, keep the calcium phosphate product less than 5. These are the 3 messages you have to remember after this presentation. And thank you very much again for your patience. Thank you very much for Professor Alia. Thank you very much, Professor Tamer. It was a real pleasure to share with you this webinar with as well with that.